PowerPoint. And I think that the projector is a little older than the computer technology, and so the connections just didn't seem to pick up. There is a USB port connection, but it didn't seem to pick up the PowerPoint. So I apologize. There won't be any PowerPoint projection, but I think the important thing is to go through this. And thanks for coming. It's a gorgeous morning out there, lots of fresh snow. I'm sure Tim Belize is going to be up there today. He was going to hike anyway, so I think he's going to have a pleasant surprise when he sees another 6 or 8 inches up at Jay. Actually, my daughter had a bit of a surprise last night because my daughter just got home from Australia, and she left 80s and 90s, and she arrived at the airport. They were a bit late. I went up to the airport last night to get her, and we got there at 7, and the flight was delayed, and finally she got in, and stepping out from the airport to go to the car was a bit of a rude awakening for her. And then she's going to wake up to fresh snow. So from 90 degrees in Brisbane, Australia to 25. But at any rate, so it's great to have her home, although we were up pretty late getting caught up. So I wanted to go over, and this is the most important part, even though we don't have the presentation. This is the important part, is understanding how we do a total knee replacement. And this, I think, came up because there were some questions. There are many approaches to total knee, and some places actually use custom jigs, and some even use custom implants. And occasionally patients will ask, well, why aren't you using custom, individualized implants? And there's a good reason for it, apart from cost, which is more for custom implants, but there's a good reason for it technically. And I wanted to, in order to understand the differences, I wanted to go through the approach. And when you think about total knee replacement, it's come a long way, but it's still not as good as total hip. Total hip is probably the single most. Did you be in and out? I was thinking you'd get your chair back. Total hip is probably the single most successful procedure that we have. High success rate. Obviously, there's always potential complications, but without complications, it's bar none the most successful surgical procedure. And they've looked at varieties of procedures in terms of adjusted quality years, and really the hip is far superior. Knee is also very successful, but not as successful as the hip. And you know, you look at the complexity of the knee and you start to understand why. And hip replacement started before knee. The first knees were done back around, it was 68, that the first total knee was done. And that was, there were no jigs. It was eyeballed, lining it up, eyeballing it. And from those early days of knee replacement, which were remarkably successful when they worked, but there were multiple complications, but they kept working and refining and improving. And then they went to development of cutting jigs, and then extramedullary alignment and intramedullary alignment. And then as it evolved, initially they would basically do what's called measured resection, which is where, to understand measured resection, when you cut a certain amount off the distal femur, you replace exactly the same amount. And so you're actually measuring that. And you have to account for loss of cartilage, you have to account for the kerf, and of course it's really an average between the medial femoral condyle and lateral femoral condyle when you make the resection. And you resect the same amount, so if it's a 9mm depth of your distal femoral condyle, you're resecting enough to accommodate 9mm. If it's 10mm on the tibia, you're resecting enough, taking into account the balance. And so the initial knee replacements were done with measured resection. Measured resection is done first. You do the cuts on the femur, That gives you easy access to the tibia. You cut the tibia, you put in your components, and then you balance the soft tissue. Now, interestingly, it was observed that when you try and balance the soft tissue in extension, now you've got it nice and straight, those same releases don't always equate to balance in flexion. The knee is dynamic. There is stability of the soft tissue sleeve throughout the range of motion. So you've already bought it. If you do your balancing here, if it's not balanced in flexion, you've already made your cuts. So actually, years ago, Dr. John Insall was one of the big proponents of going to what's called gap balancing rather than measured resection. And he basically demonstrated that if you do your distal femoral cut, your proximal tibial cut, put in a spacer block, make sure that the limb is well aligned and you have a symmetric rectangular block in extension, then you flex up and make adjustments so you have a symmetric rectangular flexion gap, that you now have a balanced soft tissue sleeve medially and laterally in both flexion and extension. And he was one of the big proponents, and he described total knee replacement as a soft tissue procedure. It's a soft tissue balancing procedure. Now, people have tried to replicate this with measured resection by doing certain specific releases, but the gap balancing ensures that soft tissue balance. So you can imagine you've got these blocks that you put in extension and then blocks that you put in flexion, and you're eyeballing this and you feel it and you try and align it. And the results were still very good. People got good results with total knee replacement because you're eliminating that bone-on-bone pain. And now it's metal on plastic. But if there's soft tissue imbalance, if there's malalignment, then you have altered stress distribution. And if you imagine someone with varus knees, there's going to be more stress on that medial compartment. And that results in stress concentration on the polyethylene. That results in polyethylene wear. The wear can result in osteolysis. The osteolysis can result in loosening. That leads to pain. That leads to revision, shortened longevity, decreased survivorship of the knee replacement. And our goal for all of us is to give them a good outcome with longevity. We want it to last. And early knee replacements would last 10 years, 15 years. Our goal is 15, 20, even 30 years. We want these to last a long time, because when you start getting into revision surgery, it's more complicated. It's longer surgery. The results are less reliable. And so our first chance is our opportunity to get it right and to give them a long-term outcome. So if we think about the evolution then, after mechanical instrumentation, measured resection, gap balancing, then along came the computer. And a lot of time was spent, the computers were around for a while, and a lot of time was spent before it became applicable. But in the late 90s, around 98, was the first computer-assisted total knee replacement. And the early use of the computer was really simply to nail the coronal plane alignment, to correct that varus valgus so that they're well aligned. And when they did studies early, they clearly showed that alignment is important. Alignment is king. If it's well aligned, then you have less wear, less stress concentration, less wear, less loosening and revision. So that was shown, but it evolved well beyond that uniplanar use of the computer. And that's in the coronal plane. But the computer is then used for multiplanar balancing of the knee, not just the varus valgus coronal plane, but also the sagittal plane in flexion extension, balancing the knee. and in the axial plane, which affects the patellofemoral joint. So the computer became the opportunity to, in 3 dimensions, balance the knee, not just in the coronal plane. And so by the early 2000s, it had improved a lot. In 2005, we started doing computer assistance, and it has improved somewhat even since then. And we're going to actually, I set this up because seeing will help you understand the process. And so when we do, and we'll demonstrate this, but when we do a computer-assisted total knee, we're able to then balance the extension gaps, the flexion gaps, the patellofemoral joint. And when you get post-operative x-rays and we do long alignment films, it's right down the middle every time. It's 180 degrees, 181, 179, but it's remarkably consistent. And studies have demonstrated this improvement in accuracy, and reproducibility, and fewer outliers. So when we do the replacement, we use the computer, the way it works, and we'll walk through this, but this is an infrared camera. These are reflective spheres in the XYZ axis, so they're recognizable different patterns that the computer will recognize. And so that we're able to, by affixing these pins to the femur and to the tibia with clamps and reflective arrays, these spheres are picked up by the camera, and then we're able to use a wand to digitize the surface, create a model of the computer, of the knee on the computer, and then we plan the procedure on the computer. The computer is then used to guide the cuts. You make the cut, we make the cut. That's probably the least accurate of the whole thing, you know. We make the cut. We verify the cut, and if there are adjustments to be made, we can adjust the cut. And then we record it. And we go on to the next step, and it all builds sequentially. And if we do make a cut that is not where we wanted it, we can adjust it before we go on to the next. And that's one of the big lessons that we learned, is how inaccurate you may have a jig that's perfectly placed. And then you make the cut. You go to verify it. Wait a minute. This isn't exactly what we planned. And so you can make adjustments. And it's remarkable how much, without even moving the jig, how much you can actually adjust within that little slot of the jig. So it improves accuracy during the process as well. And then it allows the soft tissue balancing. We assess it at the start and at the end. And I think what we'll do is go through the procedure, and then I'll talk a little bit about some of the other choices that we've made, and some of the alternatives are out there. But I think the big point is to understand gap balancing versus measured resection. And the custom implants and the patient-specific instrumentation, and even the Stryker Mako robotic total knee, it's all based on measured resection. The computer is based on a careful, thoughtful balance of the bone and soft tissue in order to achieve a balanced knee. So let's go ahead and so the way the knees we start, you know, we meet them in the ambulatory hold, we talk to them, go over the procedure, answer any questions, sign our site, bring them to the OR, do all the prepping and draping. They generally have a spinal. 99% of the time it's a spinal. They have a little sedation. And once we've prepped, draped, we actually put in some Marcaine and Exparel in the incision so that they have a little better pain relief. And if there's time at the end, we'll talk a little bit about the evolution of anesthesia and the shortening of hospital stays. It's a combination of surgical technical changes and anesthesia that's decreased that. But we'll have the infiltration, expose the knee, and then once we've adequately exposed, we've got hemostasis, We put in the pins. These are two 4-millimeter pins in the femur, two 3-millimeter pins in the tibia, the assembly clamp, and then the reflective array. We're set. Actually, Randy's not here. He's our rep for Depew. And so he's manning the camera. And we can have a look here. And we basically generate the center of rotation of the hip by simply rotating the knee, the femur, through a cone. And by adding rotation, we move it. And our goal, Justin's holding the hip to try and make sure that there's no motion occurring at the hip. In a patient that has DDH, where they don't have a well-centered, stable center of rotation, that can be challenging. And it gives you a couple of opportunities. If it's too inaccurate, you can redo it. And usually it's because we haven't held the pelvis firmly enough. And if you've got a patient that's a little bit stiff, then it tends to rock the pelvis, and then that will alter it. So it gives you the opportunity to be sure that you have sufficient accuracy of that point. And then, I think we can pop that up. This is another array that the camera recognizes the stylus, and we use this to map out the joint. So we pick the distal, the center of the knee distally. We pick the medial epicondyle. We pick the lateral epicondyle. And you can see that this all takes some additional time. The procedure does take a little bit longer, but you'll see why over the course of the procedure, why we're okay with spending that extra time. This is the rotational position, and I'm going through this. Then I usually have to flex up a little bit in order to get access. You can well imagine between these we're having to place retractors to get access to different parts of the joint, because this allows us to register the surface of the medial femoral condyle, and particularly making sure that we're around the back and have done the entire surface. And then we go into this. This is the varus position, which allows it generally opens it up on the lateral side, and then we can register the posterior aspect of the lateral femoral condyle, the distal, the anterior. And this is the important area distally and posteriorly, because that's really where we're basing our calculations. Okay, and then we set it down into extension, and this is the anterior surface. And this is important because this is how we avoid notching or avoid the components sitting up anteriorly, by knowing exactly where this anterior cortex is. And then the computer generates a model which has the most important features. The mechanical axis, the epicondyles are less important. Some people use that for rotation, but we're using gap balancing, so we're not using that epicondylar axis. So I don't worry too much about those points, but the medial and lateral femoral condyle, distally and posteriorly. Then we go and register the tibia, so it's the same thing. We start with the medial, and this, we're always careful when we're draping to make sure that we can actually feel the medial malleolus, make sure there's no excess draping right there. So we take the medial malleolus, and this has all been calculated in terms of what is the accuracy. Good. And the accuracy has been shown to be very good. The edge of the medial plateau, the edge of the lateral plateau, and it's pretty easy when you don't have soft tissue in the way. You can rip through this a little faster. And then we'll do the medial tibial plateau. There it is, yeah, thanks. Obviously, we wouldn't have the femur sitting down here when we're doing it, so this is pretty easy. This is pretty easy access. And we paint these surfaces. And we don't worry about the intercondylar notch because that doesn't play a role in the decision. So it's just painting the weight-bearing surfaces, which are the important areas, and then we'll paint the anterior and medial tibia. And obviously, we can only paint where we have to do a certain amount of exposing. So then it generates the model. At this point, yeah, we can hit next. We take a look at the knee, and typically, I think I'll put this out of the way. Great. We'll actually stress it and take it through range of motion in varus.
Record.
Yeah, let's record. This is range of motion in varus. And then we'll take it through range of motion in valgus. And of course, this one's pretty sloppy because they're just little elastic bands here, so it's not that. Good morning, Randy. How are you? Want a man there? Randy's our rep for Depew, if you haven't met him. So this gives us a sense of what's the original laxity of the soft tissue. So not only are we looking at bony alignment, we're looking at soft tissue effects. And we can see it here on the initial. And actually, let's do a little bit. That's all right. That's all right. I didn't do a full recording, but that's okay. And then we place it in extension, and we record the position. So in this case, he's got a bit of a flexion contracture here. I've just generated that with my hand, but and a little bit of varus. The problem here is that we don't truly have a soft tissue sleeve, so the balancing on this is not going to be. You can record, sure. No, oh, no, I just meant just the screenshot for the resting, our initial resting position. So that's our starting point. Okay, and then we can do our next. All right, so let's do the. Here we are. So once we have the models, we're going to go to the tibial resection. And this is an extramedullary guide, which is what people use for the extramedullary approach. We actually use the guide just to hold it in place, but we make the adjustments using the computer. So we're not just using the guide. But mechanical instrumentation, this is what you use. And you line it up. This basically clamps the malleoli. You can adjust it up and down, and you can adjust it sideways. So you can adjust your slope by bringing this forward and back, and you can adjust your varus valgus by rotating. And right at the moment, let's just, we'll make some adjustments. So right now, we're in some varus. So we want to bring it over to correct that varus to 0. I'm not sure, you may not be able to see the screen from where you're sitting, but if it's green, it's okay. We have set tolerances to within 0.5 millimeter or 0.5 degree when we're doing it. That's probably tight tolerances. Considering mechanical is within a couple of millimeters. So these are fairly tight tolerances. But we aim for it nonetheless. We've set them at 0.5 millimeter. And so you could actually, right now, it has a resection, so I can go up just a little bit or down a little bit. And these are incredibly subtle movements. And sometimes we're playing zeroitis because we're trying to get within, and there's such subtle movements and movements in one. If you change your slope, as you increase the slope, it's going to change your resection level. So you realize this interplay right off the bat. Just even placing a jig, you realize the interplay between the various factors. And I can bring that back just a little bit. And we'll go into valgus. We'll bring it up. Down, up, down, and we'll take the slope. And so we would then pin it. Once we've got our spot, we would then pin it. And Justin actually has a very steady hand, so because these are small adjustments, places the pin as I'm holding the jig, and then we make the cut. So there are pins here. This comes off. We make that proximal tibial cut. Let me take this off so it doesn't fall. I'll give you that. And I'll open the clamp. So we've made the cut. We bring this up. We set the we call this flat foot. We set flat foot on the surface, and this was already cut. So interestingly, the sawbones that they sent us has been cut in 2.5 of Varus. They didn't have very particular manufacturing tolerances. They accepted a Varus cut, because we didn't make this cut. It's already made, but and a little slope. We generally aim for 2 degrees of slope. I will look at the X-ray beforehand and see and make sure that that seems to be an appropriate. So is this resting on? Okay, let's record again. There's a little toggle, so I'll just record that. We have to make sure that when we place it on there, good. When we place it, that there's no bone debris, soft tissue, anything. It has to be flush on the surface, so we make sure we're measuring that surface. So we've made this cut, and this is where we go ahead and do our releases. If the knee is a varus knee, we have to release the medial side. We remove the menisci on both sides. We remove any spurs, anything that might affect our balance. And often the PCL has to go if it's particularly tight, or even having made this cut. The amount of tibia you need to resect, you're losing a fair amount of the PCL. And so if it's tenuous, you're likely to, you could lose it subsequently. So we'll talk about posterior substituting versus retaining if there's time later. But this is the important stuff. So we do that balancing until, it looks like this will be in the way, so I'll put it approximately. Let's bring that down. Until we're able to put in our tensiometer. And I think we're just going to have to hold it in position, because we could place those anywhere we want. That's good. I wouldn't go to, see what I mean? We could actually have those up to 24 gaps, because there's really no resistance to it. But we then, right now, you can see we still have some varus. We consider neutral alignment to be 0 plus or minus 3 degrees. If I have a 6.5 varus, that helps to tell me, you know what, I haven't done enough releases, and then I'll work on the releases to get it straight. So now I've worked on the releases, and we'll just hold it there. But yes, and there's the femoral array. I'll lift up a little bit, and we'll okay, and then we'll say there's our gaps. Okay. And then what we'll do, let's take that down. We take the tension off the tensiometer, we flex it up, and this is a little bit artificial here, so we're playing with it. But I've got to tension the lateral side, tension the medial side, and we use this tensiometer to make sure we have equal tension medially and laterally. And then we'll measure the gaps. Now I'm going to make the gaps a little asymmetric on purpose, so I'll do that. Okay, and we're at 93 degrees. Justin adjusted the flexion because we had a 3-degree slope. So instead of 90, we're at 93 degrees, and you can record there. You'll notice the medial is 12, the lateral is 13. Did it capture? Yes, it did. So now we have medial lateral gaps in extension. We have medial lateral gaps in flexion. We have some rotational information. This is where the fun starts. This is where the procedure gets interesting. We go to what's called a femoral planning screen. Let's go next. I'll take that out. This is where the computer actually calculates how to optimize the gap balancing. And interestingly, we have found the computer has a standardized hierarchy of decision making. It has a list of factors, factor number 1, and then number 2, and then number 3. So it's not balancing the factors, it's going through an algorithm. So I have, only on a rare occasion have we actually said, oh, that's perfect, that's where we're going to do it. And actually, this isn't bad, because I've played with the, as I was holding it in position, I played with it, so it makes it a little bit easier. But we're generally adjusting. And this is where it all happens. The distal resection. Where are we going to place the femur? Proximal distal. Anterior shift. Where are we going to place the femur? Anterior posterior. And this is an anterior shift. There's a flexion angle. Are we going to flex or extend? And then it'll also determine rotation. And we can, if you have balanced it in extension, and then you bring it up and you balance these gaps so that you have symmetric gaps medially and laterally, you know you have a balanced soft tissue sleeve. We look at more than that. Here's the joint line. This is a millimeter proximal and a millimeter posterior. You want the joint line to be within 3 millimeters. And we usually try and go 1 to 2 millimeters, but you want it to be fairly close because that helps to maintain balance through the range of motion. And we can get into some of the implications of joint line changes and some of the subtleties of adjustments you can make. But when we look at this, we could actually decrease the distal resection to 9. Oops, I hit it one too many times. Now our joint line is right on. We're at right where we want it to be. But now we've got a mismatch. We don't have flexion extension balance. If I had already made my cuts, I wouldn't be able to balance that. But we haven't made the cuts yet. We're planning it on the screen. And so we can look at this and say, oh, we've got 0.5 millimeter of looseness in flexion. I have several options. I can posteriorly shift, and if I posteriorly shift by 0.5 millimeter, now I've balanced my gap, but I have increased the posterior joint line. So then I have to think, and this isn't part of the computer, but in my mind I have to think, well, what was the femoral offset anteriorly? Did they have a big offset anteriorly? Because we're going to be making a flush cut here. If I take off that offset, that's going to avoid too much tension in the soft tissue. If I posteriorly shift that joint line, that's going to tighten the soft tissue medially and laterally. So I want to say, do I have a thick patella and a high offset? I could make adjustments there. This balance with this shift is way within the tolerances and of acceptability. So I would go with that. But if I had a big mismatch, let's just say I had a flexion extension mismatch of 3 millimeters. It's quite a bit. We wouldn't want that. I can adjust the size of the femoral component. Each component, we now have 10 components. So they are every 3 millimeters. So you can make small adjustments. If it was a 2 millimeter shift, I could use the posterior shift by 1 millimeter, and I could use the flexion by 1 degree, and that would combine to adjust by 2 millimeters. So I can adjust 1 millimeter, 2 millimeters. If it's 3, I can change size of the femur. You can optimize that balance incrementally with subtle changes. What the computer has taught us, though, is that every change in one plane will have impact in other planes. This is a three-dimensional problem. Think about it. We have 3 components. Each component has 6 degrees of freedom. You've got 3 translations in the translations in the XYZ axis, and you've got rotations about the XYZ axis. So there's a lot of variables, and sometimes it's hard to predict what a small change of one variable will have on another. But an example would be just take a patient that has patella baja. If I'm just doing measured resection, I can't control the variables. I can't adjust based on patient-specific anatomy and deformity. But if I've got patella baja, the patella is distal with respect to the joint line. The last thing I want to do is move that joint line proximally. Now the patella is even more distal to the joint line. So I can actually use the computer and think through, well, what adjustments would I have to make? If I make a conservative cut on the tibia, and I don't cut too much, I still have to fit in the 9 millimeters of distal femur, the 10 millimeters of the, you've got variability on the tibial side. I'm just choosing 10. But I have to fit that in extension. If I've made a conservative cut on the tibia, I have to take more on the distal femur in order to fit it in. Okay? If I've done that, I've taken more here, I'm going to have to loosen the flexion gap to maintain balance. But I've raised the joint line. So in patella baja, I have to make sure I have a sufficient tibial cut so that I don't have to take off more femur. I could even take off exactly or even slightly less in order to make sure that I have balance. And the computer allows you to make those adjustments, because then once I've adjusted it in extension, I have to realize what's the effect in flexion. And if you shift it posteriorly, or you have to think each of these. If you shift posteriorly or tighten the flexion gap, yes?
So you're able to account for leg length discrepancy with the contralateral limb?
That's a good question. In fact, in knee replacement, this is a soft tissue procedure. Even though we're making cuts, it's a soft tissue. It's soft tissue balance. This is what gap balancing is all about. If I try and change leg length, that would imply adding extra. I would put more tension on the soft tissue. And so patients often ask, that's a great question. Patients often ask, well, I've got this leg length discrepancy. I have a lady you just saw yesterday. She had a leg length discrepancy, but she had a flexion contracture. I said, I can help you by correcting the flexion contracture, but I can't go beyond that, or I will jeopardize the outcome of your knee replacement. You'll have to still use a raise if it's truly osseous leg length discrepancy. In the hip, you can make some adjustments in length, but in the knee, the only leg length correction that you can make is based on the correction of angulation. And you can imagine, watch my height. As I go into more varus, I'm losing height. And as I correct that, I'm gaining height. If I have a flexion contracture, I've lost height. If I correct that, I'm gaining height. So I can improve by aligning the limb. So our goals are completely aligned, if you will. My goal is to align the limb for longevity of the knee. It also restores limb length, but it doesn't lengthen the bone segments. Okay. So it's the angular deformity correction that changes the length, not the bone segments. So when we make a cut here, it has implications for the tibia, for the femur. When we make a change here in the femur, that has implications for the patellofemoral joint, because I may have to make adjustments in the femoral position. And so we think about this through the course of the procedure, and we think about the various factors that we're balancing. The computer is good at giving me a starting point, but I find that it doesn't balance the factors. So I'm always playing with it and trying to see what we can do to balance all the factors, not just in a hierarchical approach. Interestingly, BrainLab is the company that developed the software to allow computer assistance. And they work in concert with Johnson Johnson DePuy, the provider of the, now the Attune. We used to use Sigma with computer assistance, and now it's the Attune, which is even better total knee replacement. But they developed the software, and we were using 2.6, the version 2.6 of the software. And they actually went a step further and developed 3.0, which dynamically adjusts automatically during the course of the procedure. So that part of the problem is people didn't want to stop and think about it and think, well, what adjustments are we going to make? They want to just keep it going. And this would make dynamic adjustments as you go, as you verify cuts, as you assess stability in your joint gaps, it makes the adjustments. The problem that I have is it's based on a fixed hierarchy of decision making, so that some of the decisions that it makes based on that sequence aren't decisions that I would make. And I think we need the ability to adjust for patient anatomy. Do they have an intra-articular deformity? Do they have an extra-articular deformity? What is their soft tissue? We have such variability in our patients. I mean, you have there's such a difference between the tight, osteoarthritic, varus male or the loose, rheumatoid, lax, valgus knee. The tissue quality is different. There's research going on about collagen typing, and I'm sure that we'll know more and more about that and maybe know that ahead of time, but you can feel it at the time of surgery. When we have a tight varus male knee that's, and we're doing the procedure, you don't get anything for free. You have to do the releases. Unless you release it, you're not going to realign it. And you need to resect sufficient bone to allow accommodation of the components. If you have a loose valgus rheumatoid, the tissue stretches out. We have to be relatively conservative with our resections. So, going back to the notion of measured resection, if you do measured resection based on a preoperative study, and you use these parameters for everyone, you're not really adjusting for that soft tissue sleeve, which we are ultimately trying to balance. So there are people that are big proponents of PSI, patient-specific instrumentation. That's where they do a CT scan. And you'll hear this commonly. And it's going to be the same for robotics. It's the same for custom implants. It's based on measured resection. So how does that work? Measured resection, PSI, patient-specific instrumentation. You have a CT scan or an MRI done preoperatively. So that's an additional cost in itself. A CT scan, you have to do the hip, knee, and ankle because you have to have rotational parameters. So it's about $800 by the time and then you've got the guides, about another $800. So you're $1,500, and if you have an MRI, it's about $1,200. So you could be $2,000 up front before you even start, and then the patient has to go for another test, and they have to hold still for 45 minutes in the MRI. And if they move, then then they have to be rescanned. And you send it, you get this CT or MRI, and you generate a 3D reconstruction of the knee. So it sounds great. Here you've got this 3D reconstruction. You send it off to the company. The company creates a plan, sends it back to the surgeon. The surgeon looks at the plan ahead of time, makes some adjustments. So they could make some adjustments on that varus knee or that rheumatoid, but you're not in there dynamically assessing that on the spot. You're trying to anticipate what would that soft tissue balance be. And so they make some adjustments. They authorize it. They send it back to the company. The company, this is all possible through rapid prototyping technology where they additive manufacturing, so 3D printing, so that they can design and print or manufacture these nylon jigs with metal cutting slots and little metal rings for the pins that allow you to then have a known femoral component, a known tibial component, and they send the jigs back, you sterilize the jigs. You now have, you can understand why people want to use PSI, because it's a little more accurate than the extramedullary jigs or the intramedullary jigs. It's based on their anatomy, but it is nonetheless measured resection. But you can have the jig ready, you know the size of the femur, you know the size of the tibia, you just go right for it. It's actually easier to do a knee replacement cutting the femur first. With gap balancing, you actually have to cut the tibia first, and I'm worried about that. And this takes a little longer to do. But I believe that this balanced soft tissue sleeve is what's going to give us the longevity down the line. And it's, when we first started using the computer, this probably added 20, 30 minutes. It's half that, 10 minutes, maybe 15. It certainly adds time. But when I think about it, we're trying to get something that lasts 15, 20, maybe 30 years. What's an extra 15 minutes? If it's a half an hour of our time, we need to spend the time. We can't skimp. This is for the patient. So the patient-specific instrumentation comes back. You have all these efficiencies because you have fewer instruments, fewer trays, less inventory, rapid turnaround between cases. It's very enticing. I would love all that. But I feel like I'm sacrificing what I would almost feel naked. I feel like I'm sacrificing a lot without having this thoughtful, dynamic, intra-operative adjustment based on patient-specific anatomy and soft tissue balancing. And, you know, the computers taught us a lot. I mentioned the inaccuracy of cuts through jigs. It's one thing with mechanical instruments. And by the way, the majority of total knees in the country today are used with mechanical jigs. That's the majority. PSI is more than computer assisted. This is maybe 15, I don't know, Randy, 15, 20%, something like that in the country. And it's understandable because it does take more time. You have to have pins. You have to make sure there's no blood on the spheres or that you don't bump the array and knock it off. So you have to take care during the course of the procedure. We've even had a couple of instances where it didn't, where the computer shut down, but we were able to restart and complete the procedure and get all the information. That's only happened twice in the entire time we've been doing them. So it also requires some intraoperative stop, think, analyze, adjust, and not just plowing through and trying to do it as in, you know, I hear surgeons telling me I can do a knee replacement in 70 minutes from skin to skin. So, you know, it's not about speed, it's about quality. It's about getting it right. This is an investment in your patient's future. So the gap balancing concept is important. The other concept that has come up is natural alignment versus neutral alignment. So if you know some people, they're just naturally conivarous, you know, you see the front. And that's a predisposing factor for the development of medial compartment osteoarthritis if you have a varus knee. If you're invalgus, it's a predisposing factor for lateral compartment OA. We know that. So the concept, Otis Med was a company that promoted natural alignment. And they got traction for a number of reasons. One is that if you are doing your knee replacement and your goal is to restore the pre-arthritic condition, and the rationale for that is that you're restoring soft tissue balance to their pre-arthritic condition. So yes, you're getting soft tissue balance. The problem is it's at the expense of alignment. So if they had a natural predisposition to varus and you restore them to varus, the very forces that led to the arthritis are the same forces that are going to lead to the wear of the polyethylene. You can imagine if you've got someone with a knee replacement that's in varus, you're going to put more stresses. Again, stress concentration in one area on the poly leads to wear. Wear leads to osteolysis. Osteolysis leads to loosening. Loosening leads to revision, decreased longevity. So it didn't make sense, but I could see why the traction, because if you don't have to release, shorter surgical time. If you didn't have to release, you'd have less blood loss. Less blood loss, less bleeding post-op, less swelling, less pain, easier rehab, shorter hospital stay, decreased cost. Yay, we're winning. They were left in malalignment, companies out of business. They had lawsuits and early failures. So I don't think we can take these shortcuts. The other area was the kinematic alignment, which is really another form of natural alignment with measured resection. And there's some very smart orthopods. The problem is, I mean, I'm thinking particularly of this one guy that's a big proponent of kinematic alignment, and he's a very smart guy, PhD in California, and has his line, but there's a tremendous financial incentive to promote the product and the concept. And the concept is that failure is due to instability more than not alignment. And I totally agree, instability is a cause for failure. So we want a stable knee. But I want both. I want it well aligned and stable. And to do that, I think this is the approach that we take. So there's lots more we could talk about. I think I should leave some time for some questions. The big thing I want you to understand is that computer assistance allows optimization. It takes gap balancing to the next level. John Insall with the gap balancing blocks was onto the right idea for that soft tissue sleeve. And the computer just allows us to do that to the next level and adjust various parameters during the course of the procedure based on the soft tissue response. And you know, if we have a cut that is slightly off, we can adjust it in the femoral. Let's say my distal femoral cut is off. I can go back to the femoral planning screen and rebalance the knee. I've cut a little bit too much, so I can go back, plan it, and so I can, even if that cut wasn't exactly where I wanted it, you can make those adjustments. So if you're doing a PSI or you're doing a custom implant, you don't even verify the cut. You don't know that the cut's off. And so if the cuts are offsetting, there's no problem. We got a little bit of varus here, we got a little valgus there, it's offsetting, the knee's pretty straight, okay, we're good, we're happy. But if those are compounding, now you have outliers. Now you're in valgus or varus, and you've got that malalignment. The computer has been clearly shown, and there's studies upon studies that have shown increased accuracy, reproducibility, and decrease in outliers. Gap balancing, computer assistance, it doesn't happen with a custom implant, which is already decided and positioned and planned based on preoperative studies. And yes, that's seductive, and yes, it's it's a marketing, a great marketing. Oh, this is a custom implant just for you. This is actually more individualized using the computer with 3mm increments and components and individualizing its position, customizing to their soft tissue balance, as opposed to customized to their specific bony anatomy, which is all you can do with planned preoperative PSI or the measured resection and custom implants or even robotics. So although these other things came after the computer, I never saw them as being an advancement. I saw them as being efficient. I saw them as being marketing. I saw them as being expensive, but not better. So until I see something that I think is truly better for the patient, we'll continue to plod along and spend a little extra time and try and do it right with the computer. I'm going to stop there because there's lots of other things that I never even got to, but are there any questions that, or have I bored everyone to death and they're ready to go out and play in the snow? Yes?
So we've all seen these patients that come in, they're bilateral OA, there may be valgus or varus bilaterally, so they have your computerized alignment, they do great. I mean, these patients really do well post-op. But now their other knee is still valgus or varus, so now they feel like they have this leg length difference, yes. Right? So, they lengthened my leg now. Not truly, but they lengthened my leg because you've taken the flexion contracture out. So they still have that problem on the other side, so they're kicking over.
Yes.
I've given them a lift before just to try to balance.
Absolutely. Absolutely, that's fine.
Yeah.
And I think that's a good point. And in fact, if you give them a lift on the other side, you may help. Sometimes they'll compensate on their total knee side because the other side is varus and flexed, that they're not fully extending their total knee side. So you may actually be helping the rehab of their total knee by using the lift on the other side until such time as they can get the other side realigned and straight and then leveled. So I think that's a very good point. All right, well, it's 8 o'clock. But no, I shouldn't have said that. Any other? If there's any other questions. Well, thanks for joining us on this beautiful, snowy Friday morning. And enjoy the weekend. It looks like it'll be a fun weekend for some people.
Thank you.
Okay, you're very welcome.